Hello, welcome to a special American Psychiatric Association Foundation video podcast, Connection to Care, Part 1. Communities across the country are actively working to address how individuals with mental illness enter our criminal justice system. A key piece to ensure they either don't enter in the first place or don't come back to the system is making sure they get connected to the support services that they need. Two of the crucial questions communities should be looking at in addressing connection to care are: one, did that person make it to their first appointment? And two, did they like the provider and feel engaged? The ways in which communities address these questions can be vastly different, but there are some key things every community should consider. We need to understand our state and local systems, the barriers and facilitators that may exist in those systems, and the support services that should be included when connecting individuals with mental illness to care. We invite you to listen into this conversation with Donna Struger-Fritsch, Dr. Brian Hurley, and Dr. Jeff DeVito.
Hello, everyone. I'm Donna Strugar-Fritsch. I am a correctional healthcare expert. I'm a consultant, and I've been doing correctional healthcare consulting all over the country in prisons and jails for 18 years. And in the last, all of it has involved detainees and inmates with serious mental illness, and recently, much more so, as well as a lot of work with jail detainees and prison inmates who need their substance use disorders treated, particularly opioid addiction. Happy to be here today. I'm located in California, but I've done work all over the country.
I'm Brian Hurley. I am an addiction psychiatrist based in Los Angeles. I work for the Los Angeles County Department of Health Services as the Director of Addiction Medicine, and I provide clinical services as a general psychiatrist and as an addiction psychiatrist in the LA County Correctional Health System, the nation's largest mental health hospital, as it were, providing mental health care to the 17,000 inmates that are served by the LA County Correctional Health System.
Hi, everyone. My name is Jeff DeVito, and I also am an addiction psychiatrist and also currently located in California. And I wear a couple different hats. One of my hats is as Chief of Addiction Services for Marin County, California, in the Department of Health and Human Services here. And I'm also the Behavioral Health Clinical Director with Partnership Health Plan of California. In my role in particular with Marin County Health and Human Services, I've been heavily involved with a number of grants related to expanding treatment options for incarcerated individuals here in our county of Marin.
What should you know about your state?
So, Donna, again, thanks for being here. I think back to when, around the time that Dr. DeVito and I both finished our clinical training. And we both took positions in local systems of care, and in this case, county systems of care, where we are faced with building capacity in connection with our local correctional health systems for behavioral health needs that we need to deliver community members when they're incarcerated and when they're on release. And Dr. DeVito, I don't know what your experience was. Mine was, well, we know these technologies. We understand medications, we understand counseling, we understand support, and we understand the intensities of the systems under which those can be delivered. So, maybe have a 45-minute or hour-long conversation with, the leadership in the county level, and clearly that will solve everything. And I think what Dr. DeVito and I both realized is that there is a multi-layered landscape that has a direct impact on the availability of behavioral health services for community members who are justice involved. And so I'm wondering if you can tell us more about the landscape. That is, what should both clinicians but also policymakers know about the landscape for behavioral health services for those that are justice involved?
So, such a great question, and it really varies intensively by state and then within states as well. But keep in mind that your clients' patients are going to be released or receive services in very complicated systems that are important to understand at the highest level, one of the first questions is, in my state, has Medicaid expanded or not? And that goes, has to do with how the state responded to the opportunity to expand Medicaid under the Affordable Care Act to low-income adults, which essentially is most of the people in the justice system. In states that have expanded Medicaid, there are often expanded behavioral health benefits for certain pieces of the continuum, like residential care and other types of care, and particularly for substance use services. There have never, in traditional Medicaid, there isn't substance use treatment robust benefits, but under expansion, there is. And so the first thing you need to know is, did my state expand Medicaid? And if so, what are the benefits that are available for behavioral health, for psychiatry, mental health services, and also for substance use treatment? You also want to know, how does your state manage between the Medicaid publicly funded system and the state public behavioral health system? So Medicaid pays and the state behavioral health system administers or delivers the services. How do they differentiate between people with severe mental illness or severe and persistent mental illness, depending on your terminology, and people with mild to moderate mental illness? So where does your patient fall? Is your patient going to fall into Medicaid and stay there, or is your patient going to fall into commercial or managed care and stay there, or is he the unlucky one who's going to bounce back and forth between, which becomes very difficult to manage? And some of that is more than state, it gets to be local. But at the state level, what does your public mental health system look like? And how is your state managed care and commercial coverage working? Is there parity with medical services, or are mental health services really skimpy? And what's it like? And for your patients that have the most severe mental illness, what does your state hospital system look like? Is it jammed to the rafters? Is it full of people from the prisons? Is it full of people waiting, or who have waited for months in jail for restoration to competency? What does it look like, and where is your patient who needs a state hospital going to fit into that? And you don't have to know all the gory details, but understanding the moving parts and how they relate to one another and where the bottlenecks are is going to really help you in feeling comfortable and helping your patients to navigate. The last piece would be knowing how the state prison system works. In general terms, for services to the mentally ill, and how the reentry planning works, and what post-release parole services for mentally ill people look like, how they're characterized, how they're structured, who pays for them, and is it the regular healthcare system that the person falls into to receive those services, or is there a parallel universe of carriers and providers, which is the case in some states? So there are a lot of things to understand. And so probably what you need most of all is a smart ally that can just educate you in this landscape.
Dr. DeVito, I wonder if you have any questions about the local system.
Well, I was going to emphasize, thank you for highlighting all of those various aspects to delivery of care, both within within an incarcerated setting, but sort of outside of it, and kind of acknowledging from 30,000 feet again this idea that when we talk about this notion of what can we do to enhance the connection between an individual who's in an incarcerated setting and like the community, for example, or how do we connect an individual who's in an incarcerated setting with treatment? What you're saying is that what is essential is a real desire on one hand to understand the local system, and a real desire to understand where that local system sits into bigger systems, because if we're going to enhance connection to treatment, we need to understand that that doesn't happen in isolation. It's just not one provider to one provider, that this happens and is contingent on many different things that are happening both at the local level, and every local place where I've been would highlight this, and I think you all would echo this, that that every locality is going to have some unique aspects that need to be understood in order to make the changes or to enhance the connections that we're looking for in the system. You know, and just as a simple example, I can provide from working in for example, in Marin County, the different even understanding sort of who provides the different services, that they might not fall under the same umbrella. Social services may fall under one umbrella within the county infrastructure, or mental health services may fall under another, substance use services may fall under another. And I know when I started this work, it kind of blew my head apart trying to figure out sort of like who was who. And to emphasize Donna's, I think, sage advice on finding a smart ally, really asking and being open to hearing from different stakeholders about their understanding of the system. And that's how you build out an understanding of sort of both local and sort of where local systems fit into broader systems.
Mm-hmm. And there can be real additional unique features of local systems, right down to the level of how a particular county handles involuntary medication, for example, in that county, and whether the jail is able to provide involuntary medication. You also will find that you'll need allies in the justice system itself. So if you're working with the population that's moving in and out of jail frequently, you'll be best off if you have an understanding of how the probation system works, how the public defenders and district attorneys consider their charges in that community, and how the courts act, because in fact, a lot of what happens to your patients, even clinically, is affected directly by the courts. And surprisingly, you know, a psychiatrist and a judge can have a really good conversation at the local level about what's best for patients. And sometimes that's the best thing to have happen, is to just develop a relationship with judges, as odd as that may sound, where you can trust each other to advise each other to fill in your knowledge gaps. There's also enormous differences at the local level in managed care organizations and health systems, and who the players are. And also, as Dr. DeVito mentioned, the human service agencies, for example, in some communities, it's going to be the Salvation Army that provides the bulk of what your patients are going to get. And that's philanthropy funded or private donations. So understanding the safety net actually at the local level is what you need to do. What is the safety net for this patient of yours, and where are the holes in it? And again, you shouldn't have to figure that out by yourself, but the picture can change a lot from year to year as well. So it's a fluid, the safety net is a fluid thing where holes get closed and other ones open. And I'm sure that you two doctors can speak to how you have to bang your head against that.
So as I mentioned in the introduction, one of the places that I see patients is the LA County Jail. And in the jail system, it depends a lot on, is this patient incarcerated related to their involvement with drug court, criminal court, exactly what was their pathway into and therefore out of the jail system. And even if there isn't a drug court judge that might sometimes try to make medical decisions in terms of directing a community member who's incarcerated to a court dictated level of care, or even more granularly, a court dictated medication, I'm then left with, well, what's the community system of care? And in California, we have trifurcated funding streams for our Medicaid system, which is called Medi-Cal. And so, you know, do I get this person access to, say, a medication for addiction treatment through a community health center? Do I try to get this patient to a specialty addiction treatment program? Do I get them to a community mental health center? Well, those are three actually completely different systems. And odds are, if I get the patient access to the meds, then there might be some friction with getting them into psychosocial treatment and the appropriate intensity of addiction treatment care. And conversely, if I can get them into an addiction treatment program, odds are they're not going to be able to access medication support that they would need in order to be able to thrive post-release. And so understanding the pathway in the local system is really important for me. In order to be able to link my patient to continuity services that it's going to, enhance their health and improve their well-being and reduce the chances that they're going to return to custody. Conversely, some of our patients who end up in the state correctional system, they come out of state corrections, and in working with the California correctional system, there isn't one pathway to get a patient from the state system back to a county system of care where they reside. And so we see sometimes the state prison system sending people to the mental health system, expecting the mental health system to know something about addiction services, sending people to addiction treatment centers, but not necessarily understanding that most addiction treatment programs aren't licensed or supported in doing community mental health. And so this trifurcation of funding streams has huge implications on how do you actually connect the patient to an integrated system, because our system are by regulation funding essentially siloed away from each other. And like you mentioned, Donna, the relationships that you have with which community health centers are effective at interfacing with the correctional system, that can work with probation, that can work with parole to be able to support people with the services that are necessary, is almost never a straightforward process. And depending on exactly where in the community people live, you either have a robust set of resources or a real dearth of resources. And that's why knowing the local communities is so important, is because at least I've yet to see a one size fits all model. If you just give the patient, send the patient this referral, then everything will succeed. It never works that way. Thanks in part to the state targeted response funding that came down from the feds, and has now been a few waves of this STR money. States have been building capacity for opioid use disorder treatment, including paying folks like Donna to be able to come in and do technical assistance and be able to build capacity. Where I've seen local systems oftentimes fail to capitalize on those grant-funded opportunities, and it doesn't necessarily need to be federal money, it could even be local philanthropy, is in building a standalone program funded exclusively on grant money. Because when those standalone programs funded exclusively on grant money, when that grant money goes away, the programs go away. But if what you can do instead is build on the platform of an existing program, a program that's already connected to some sustainable funding, whether it's Medicaid dollars. In California, we've got another large source of mental health funding called the Mental Health Services Act, or MHSA, ongoing sort of tax revenue money that is allocated to the community mental health system, or a block grant funding from SAMHSA. But if you're connected to an ongoing funding stream and you use grant money to be able to build capacity in existing programs and then connect those programs to longitudinal funding, then that's a smart use of philanthropy or a smart use of grant money in order to build capacity where there wasn't before. Where I've seen local systems sometimes go awry is they think, oh, this is a special mental health program, so we're going to hire an entirely dedicated staff with an entirely separate system. And those systems, unless they're connected to some ongoing funding support, invariably end once the grant funding ends.
And I agree with that. And actually, in the states that did not expand Medicaid, we often see more creative uses of funding streams, and we call it braiding them. And because they don't have a benefit, and so they have to be more creative and braid things. But even in an expansion state, the more you can braid funding, when one piece of the braiding starts to fray, the others at least are still there. And so it's very, very complicated. And another thing that's really complex is assuring that co-occurring disorders are adequately addressed in systems. One of the biggest challenges out there today is that for the justice-involved population in particular, a good 70% of people with serious mental illness in the justice system have a substance use disorder. But even inside the jail, those systems of care are very siloed. And when you leave the jail, it's even worse. And treating, the state hospitals have the same challenge. Treating the psychiatric disorders in the absence of addressing the substance use does not give you the best outcome for either. And we've seen in California that in our state hospitals that sometimes when the substance use disorder is aggressively addressed, the person's psychiatric illness just wanes and they go home. And it's that dramatic. So I would say that a real challenge for you practitioners is to make sure that you and your peers and your community processes address the fact that this population has a very high co-occurring disorder rate. And similarly, if you're only addressing the substance use disorder, but the underlying cause of it is PTSD, if you don't address the PTSD, guess what's going to happen? So this population really demands a good integrated, aggressive co-occurring disorder approach, which frankly, nobody's very good at right now, but I have hope that it can get better. And that, that's an overstatement to say nobody's good at it, but you guys should chime in.
When I think of system barriers and facilitators, I think about the patients that I see in the LA County jail system. And I work as part of the mental health team. So everyone that I see has been assessed by a clinician, has a DSM-5 diagnosis, and is actually housed in dedicated housing where the community members that are incarcerated can receive increased supervision from custody staff. And what was so striking to me in the way that my own county health system rolled out medications for alcohol, opioid, and tobacco use disorders is that the mental health system was not included as where we were going to initially roll out our medications for addiction treatment. Right. It was initially rolled out with a set of inmates in the central jail, the non-mental health housed area of jail, for a really selected group of inmates. Now, I can understand why custody wanted to have a dedicated program to support the delivery of medications for opioid use disorder. It's an understandable impulse. But the side effect of that is that if you don't involve the mental health system working in custody, then you've got some people who are identified at some point as having a, quote, mental health disorder. And I will say the comorbidity of substance use disorders among the inmates I see, it's 80%, right? 80% of the people that I see with, at least nominal mental health conditions have co-occurring substance use disorders. And yet our area of custody doesn't have access to the tools. And that's within one correctional health system, right? We don't have access to the tools that we need in order to be able to get a patient substance use disorder treatment. And yet for community members that find themselves, in the general part of custody, they don't necessarily have access to the same intensity of mental health treatment in order to be able to definitively resolve any mood, anxiety, or even subsyndromal psychotic symptoms they might have in order to sustain recovery. So even in one correctional health system, I've experienced barriers in the way that care is organized that makes it hard as a psychiatrist who actually I pride myself on delivering integrated care, but I can't in the system. And Dr. DeVito, I don't know if you've had any sort of experiences in Marin County that mirror some of this siloization and fracturing of care that is the exact opposite of what we know is clinically helpful for community members that find themselves in custody.
Yes, and I would emphasize another point that Donna, I think, brought up earlier, which is that the system of care that we're talking about now, sort of within, incarcerated settings, like this is not unique to just that setting. We see this sort of in community mental health settings. We see this in community substance use settings. This is sort of the siloization, if that's a word, of the services is not unique, and there are forces that drive that. I mean, there are, as Dr. Hurley mentioned before, there are financial and sort of structural forces that drive sort of, no, this is my silo, this is all I do here because I can't bill for doing anything else within this silo. And that works against, I think, some of the clinical training that many of us have had, especially those of us in addiction psychiatry, where we really are kind of taught to kind of look at the individual and treat the individual sort of as sort of a unified as a unified person with multiple, potentially disorders that require our attention, whether it's mental health and substance use or medical for that matter on top of that. So I think that for those that might get a little, less people get sort of glassy eyed as we talk about the layers of complexity with this specific system in mind. It bears kind of, remembering that this isn't just limited to this system, so that the strategies that one might think about employing within the criminal justice system have some unique aspects that are specific to the, to the system that we're looking at, but they also apply in other places. And
Mhm.
as an example, I know Dr. Hurley, you asked me sort of examples from my experience in Marin County, kind of provide one idea of an approach. One idea, that we instituted that I think was incredibly helpful and eye-opening was that you look at the different layers of complexity in what we're talking about, and you have to pick a place to start. You have to pick somewhere where you're going to try to gain an expanded understanding of what's going on. You could start at the top, and you could start at this, reviewing sort of and talking with people about what's happening at the state level or at the federal level and work your way backwards to locally. You could start locally and work your way back up, all the, and meet somewhere in between, whatever it what strategy you might choose to use. One thing that was helpful for us was with the grant funding that was mentioned earlier. We used a big chunk of that grant funding to actually bring in an epidemiologist and a real sort of data scientist person to help us look at where is the data, how does information flow within our, within our jail, within our mental health system, within our substance use system of care. How does that information, where does it sit, where does it live? We found that we had multiple different, I won't say they're EHRs, but we had multiple different electronic repositories of information. We had multiple different sort of paper repositories of information. And then we had a whole different repository of information that was kind of individual specific, like that there was this person with this institutional knowledge of this part of the system. And our epidemiologist was really helpful in helping us, understand where the information was and where the data was so that we could start somewhere. We could start by saying, oh, this is interesting for this for this particular population of people. Let's say, I'll just give a real example for this, for individuals that were coming in with opioid use disorder that are reporting being on methadone, for example. We don't know out of the gates how many of them are actually getting methadone as part of our methadone delivery system to our particular jail, until the epidemiologist was able to come in and be able to connect the data to say, okay, we're actually pretty close to, if not at 100% of people that are coming in who are on methadone that are continued on methadone. This allowed us to say, okay, check. So we've got one
Right.
area that we can kind of put aside and say, this area we're doing well in. We don't need to spend a lot of our collective efforts on that. Meanwhile, at the same time, looking at that and saying, okay, well, then let's focus on the buprenorphine, or let's focus on naltrexone, just picking medications, for example, but also looking at that and saying sort of, okay, well, can we look at a population level? Which are the people that are that we have access to understanding, even do they make it to their first appointment? Like, can we even ask that question? Do we have an infrastructure that would allow us to ask this question and get and know whether whatever we do is resulting in some improvement or keeping the status quo or making things worse. Hopefully not. So anyway, from Marin, we picked as an entry point into thinking about this, in some ways, kind of a third party that could come in and give us a map of the system and from a data standpoint as a starting point, so that we could say, okay, well, we really have trouble with communication between these two parts of the system. This part of the system we're doing pretty well in, and then we could focus our efforts.
Sounds like that was grant money well spent, Jeff.
It was. Thank you to HMA and the state and the feds for granting us that opportunity. It was very much, and we have retained that epidemiologist, just as an aside, because of the value that we recognized very quickly that was brought. And that particular epidemiologist was also very, very helpful in us organizing our COVID response efforts sort of as a county, and also, thinking of the COVID response within the jail system, because that particular epidemiologist really got to know our system and really understood sort of the complexities of it, and could help then translate it to us in a way that would have been really hard for us to do on our own without that lens through which to see it.
So Jeff, you highlighted how the silos in the system ironically required you to hire an epidemiologist to map out how information flows where. And Don, I'm wondering, are there other opportunities that are created in this milieu, right? We've talked about the barriers, but what are the opportunities associated with making change in a soon to be fractured system between corrections, community mental health, community substance use disorders, and all of the different structures that affect justice involved community members?
Well, that's an interesting question. So opportunities flow from a common interest in reducing crime and recidivism, and on the other side, reducing overdose and death. There's a lot of interest in all of those things in every community. And we are at the cusp of an open faucet of resources right now, which it might not feel that way to you out there in community land, but all the opioid settlement money and all of the funds that are coming to counties for COVID structural developments really are opportunities to, they're resources that can be directed at these issues. What you need is a common language in the community that brings the parties together to agree to work on these types of things, and creating a data system that tracks the outcomes that Dr. DeVito was talking about, plus COVID stuff, plus recidivism stuff, is complicated, but very doable if there's interest. The harm reduction community is going to be real interested in this. There's all kinds of people that really care about doing this. And it is a unique opportunity over the next 18 months, I'd say, for resources flowing into states and counties that could be used for this if there's smart people that are willing to articulate it. Another opportunity is to, I was going to talk about this a little later, but it is the opportunity for you as providers and psychiatrists to really pound on the community for long-acting injectables, and to help your counties and payers get over the price tag, which is only one way to look at the expense of these medications and what they have to offer. The more use of long-acting antipsychotics and long-acting opioid and other opioid addiction treatments can have profound impact on persons staying stable, your patients staying stable while they're working hard on navigating the system. And there will be new resources for those as well. And you could really have a bully pulpit there, especially if you can in a long shot, join arms with your sheriff on these things. It could be pretty amazing.
I
What do you
think
guys think about that?
I think to echo that point, I would harken back to a supervisor that I had during residency that used to abide by the statement that when treating someone with an illness, any illness, part of your role as a clinician is offering all of the potential treatments that could be available for that individual, and then working with that individual to determine which is the best course of action for that individual. And I think that we do see that a lot in, not just in and I would say not just in jails or prisons, but I think we do see it a little bit more in jails and prisons than in other places, where there are sort of external forces that kind of restrict the the range of treatment options that you can offer.
Right. Mhm.
And as clinicians, that kind of that can be a very uncomfortable place sometimes, where there might be additional treatment options that you might consider talking about with an individual, but maybe those aren't available in that setting, whether it's a hospital or, in this case, as we're talking about today, in a jail or prison setting. And thinking about, well, how do you keep those conversations clinical, from the
Mhm.
standpoint of how do you make a clinical case for the merit of having available these additional tools. And
Mhm.
for me, that's always been the place of sort of my safe place when having these conversations, is coming back to saying, listen, let me give you an example of an individual who for whom a long-acting injectable medication really is going to be not only better for them clinically, but also potentially better for the community at large, and potentially easier for you as custody staff when
Yeah.
when working with this individual. And let's kind of walk through this, and again, not violating any privacy rules or anything like that, but let's talk about specifics where the clinical management of this person can be our focus, and then work our way from there, from a shared understanding of sort of what clinically we're talking about. So then we can start sequentially moving further and further out to those other layers that we've talked about today, from sort of the local jail or prison staff issues out to sort of the state and sort of national levels when we're talking about funding,
Mhm.
and how to pay for it. And I'm not sure, again, Dr. Hurley, if you have had similar experiences around those conversations. And I think it's interesting to juxtapose, in some ways, Dr. Hurley's experience and my experience from the standpoint of scale.
Mhm.
I'm talking about in my county, sort of a 300 capacity jail system versus, as Dr. Hurley mentioned before,
17,000.
17,000.
Yeah.
Yeah.
So in Los Angeles, there are so many domains of activities that impact a justice-involved community members' experience. There's the correctional system, which can be loosely split into what does the sheriff do with custody staff, and what do the clinicians do, the clinical staff. And sometimes in many jail systems, the sheriff hires clinical staff. Many county systems contract out with clinical staff. Where I'm in a system where one county department manages the clinical staff, but another county, so our health services department manages the clinical operations. The sheriff's department manages the custody operations. And oftentimes, custody is welcoming. Yeah, we'd love to have an expanded range of options, right? They're sort of unencumbered with a lot of the clinical stigma that comes with the treatment of people with substance use disorders. And they're like, yes, treatment is good. And the idea, and trying to sort of orient custody to, well, there are these treatment options, and here is the evidence, and here's what we can do with psychiatric medications. Here's what we can do with medications for addiction treatment. Here's what we can do with different formulations of medications that are available. A lot of that is news to people who aren't trained clinically. And so it's sort of tough to know what people don't know until you have a conversation. And this is something that I think Donna has spent her career doing, is convening people, right? Mm-hmm. Convening stakeholders to make sure that everyone has foundational knowledge and information to which to make decisions. Because if you have the clinical people in custody working in one direction, and you have custody that has no idea what's going on, people can unintentionally work towards cross purposes. And that doesn't even count then what happens after with probation from the county system or parole from the state system, where that doesn't even count the oftentimes cadre of community-based organizations that are trying to support people thriving in the community. They may not necessarily be resonant with what happens in custody or be able to navigate the community mental health and behavioral health systems sufficiently in order to support people. And so it really does speak to the need, and I would say an opportunity of if you don't know what everyone knows, then you can assume that there will be discord. Then you can assume that people will be working at cross purposes, and it speaks to the importance of convening all of the stakeholders for justice-involved community members. So for a community member that's justice involved, Dr. DeVito and I are psychiatrists. We think in terms of medications and counseling and support and clinical services. But Donna, I'm wondering, what are the other support services that would be needed in order to support somebody thriving in the community, potentially on release, or even if they're diverted out of custody? How can we support people, including but beyond the provision of clinical care in order to support people's thriving while remaining in the community and out of incarceration?
Right. So that's a $1 million question, and not something that psychiatrists are trained to really manage. But first and foremost, a large portion, as you all know, of this population is homeless. And so housing is of the utmost importance and of the least availability. Transportation is also a really big deal to get people to where they need to be. Employment and educational opportunities and food are also really important. And fortunately, there are hosts of community organizations that exist to help this population get those services. But the challenge on top of all of it is the case management. And, on the healthcare side, we got so good at case management over the last 15 years that we're dying from it because there are too many case managers or care managers who each have their own job and report back to their organization. But unfortunately, almost none of your clients or patients have a care manager that crosses all those systems. And I think that we're going to see more of that in the future, especially for the smaller population of people who are at the most risk, the people with the most serious illness who keep going off their meds and end up back in jail over and over, or bouncing from the jail to the state hospital, back to the street, to the jail, to the state hospital. So care management is, I think, in order to make any of these other things work, some sort of integrated or concentrated care management, particularly by a person with lived experience, either with mental illness or with the justice system, even better, or best of all, with both, is really what is the ticket to success for your patients. Very few people get that, right?
Yeah, I know. I was thinking of in Los Angeles County, and this was a statewide program, but in Los Angeles County, we had a community health worker program called Whole Person Care, which actually showed a tremendous impact. And there was a lot of focus on justice-involved community members. And essentially the case managers were community health workers with lived experience. The idea is that was a very important component of supporting people with folks who'd been through custody themselves, who, you know, their familiarity with these systems wasn't in board meetings or, you know, wasn't an academic understanding. It was people who'd been through it themselves.
Or, you know, I mean, I had this job years ago as a care manager in a managed care organization. I sat in an office and tried to talk to people on the phone. And you know what? For your patients, that is not going to work.
It's not going to work.
Not going to work. So good care management that can weave in and out of all of these determinants, social determinants of health and safety and the justice system is, and be able to communicate with the person in whatever state they're in is the challenge, to make all of those moving parts come together on behalf of that person, large county or small county.
So I think back to the point about sort of like understanding some of how things on a national or a state level impact significantly on what happens at a local level. I can kind of provide another layer of example to this. Recently, as Dr. Hurley mentioned earlier, you know, and Donna had mentioned earlier, California had expanded Medicaid under the ACA. With that came also some additional opportunities for pilot expansions of different kinds of services that traditionally had not been covered by Medicaid. But with the ACA, there became some opportunities to pilot some of these activities. And in California, we took advantage of that in the form of what's called sort of with the acronym mouthful here, the DMC ODS, which is the Drug Medi-Cal Organized Delivery System. And what this system allowed basically was, or what this system is a pilot program to allow for, as it played out in California, allow for counties to draw down Medicaid funds for services that were not traditionally covered by Medicaid. So why am I going through all this? Well, I'm going through all this because one thing that we were able to do in our county, and I think other counties have taken advantage of as well, is utilizing some of that additional funding stream to support the activities of what we call recovery coaches. So for us, the recovery coaches are all certified drug and alcohol counselors. So many of whom have lived experience and have talked publicly about that, and some don't. But nonetheless, these are individuals with a real passion for the work around treating and helping people navigate the system who have substance use issues. And in California, there are 3 certifying organizations that certify that are recognized by the state as certifying drug and alcohol counselors. So these individuals are individuals that have gone through these either of these 3 organizations and have gotten their certification. And they are very, very intimately familiar with, in particular, our local system of substance use treatment. And you know, I lean on them pretty heavily when it comes to helping to navigate, you know, individuals between different parts of the system. For example, they'll know sort of who the particular staff are at a particular agency that makes that agency slightly different than a different agency, and be able to do some better matching. They will pick people up, they'll bring them to, you know, from point A to point B. And a lot of these care management activities now are now sort of reimbursable through a pathway that didn't exist, let's say, you know, 15 years ago. We've had the advantage of being able to capitalize on that because we're a relatively small county. You know, it's obviously, as scale gets larger and bigger counties, you know, and the systems become more complex, you maybe need more, or you know, you might approach that system a little bit differently. But for us, these recovery coaches, and we have 5 of them, and sometimes our recovery coaches have their funding sort of braided with other funding streams, like in California, other justice system, you know, funding, for example. So we have 2 coaches that really are tied to specifically justice system funding streams, AB 109 being one significant funding stream, which relates to the prison system and the jails and sort of movement of people between the two and funding for that. And then secondly, through our adult drug court, that we have additional funding, a different funding stream that helps support a coach to be stationed kind of with that program, and can kind of move in and out of different parts of the system to provide that complex care management that Donna was highlighting was so important. And these are folks, I mean, they understand the housing system. They're my utility players, as I like to say. They can play any position, and have really become a really invaluable part of our network, because they hold an institutional knowledge. And also, I would add, what really makes them different is that they also share a particular passion for working with individuals with substance use that have specific needs around that. They can really speak to that, to those unique needs, based on the fact that they have this shared passion.
Thank you for joining us for this special American Psychiatric Association Foundation video podcast. We hope this conversation provided you with the background necessary to get your community started and ensuring community members are connected to care. Remember that 2 of the questions you should be considering are: 1, did that person make it to their first appointment? And 2, did they like the provider and feel engaged? Stay tuned for part 2 of this conversation. We want to extend a great thank you to Alchemies for their support in the production of this video podcast. And thank you for listening.